Welcome to the Health Deli, your local stop for a fresh take on community health topics. Come on in, grab a number, and let the guys behind the counter, Mark, Ben, and Mike, tell you about today's specials.
Well, welcome to the Health Deli. Today I have with me the co-host, Dr. Benjamin Pontefract.
Hello, that's the best my name's ever sounded, I think,
Really?
ever.
Good.
Yeah.
I'm glad. Well, yeah, that's good. That's good.
I think so. Yeah, I'm having a great time here. We're we're not live, but we're here again in the fantastic Health Deli Studios.
Second episode that we've done here.
Mhm.
This place is amazing.
I am still shook. I am shooketh, as the kids say.
Shooketh. I like
Yes,
that.
it's
Is
good.
that a millennial thing or Gen Z?
I don't know anymore.
Shooketh.
It might not be anything. It might not be an anything thing. But yeah, so we're here in the Health Deli Studios, again, at the center of virtual learning here at Ferris State University. Absolutely beautiful place and a lot of fantastic technology that we've been able to kind of kick our game up for this season 3.
Yeah. We used to be in the basement. They didn't let us up. But now that we're in the Health Deli Studios, I can see a tree. I can see students walking around. It's great.
It is much better than the basement. That is true. Where it was just concrete walls, some styrofoam for volume control.
I think these mics sound better too.
I think so. They're really good.
Yeah, maybe even Mike will sound okay on these.
Don't hold your breath.
So, topic of the day is going to be potentially inappropriate medications in geriatric patients.
Geriatric meaning.
So we're going to talk about exactly what it means to be geriatric.
Okay.
But before that, what have you been working on?
Yeah, so I teased this a little bit in the last episode, but the big thing I'm working on right now is essentially air pollution, how that affects our health. Is there anything we can do about it? And yeah, getting my friend on board, an economy professor who's really just recently published on this. So hopefully he has some pretty cool up-to-date information and we can all talk about it.
That does sound interesting.
Yeah.
How the environment maybe impacts our health, kind of.
Yeah, for sure. Talking mainly about air pollution, but that is probably another topic we could talk about is just how our immediate surrounding affects ourselves. So that's a good idea. Yeah, so that's what I'm working on. Are you working on anything, Mark?
I'm working on a couple things. So my I teased this at the other episode too. My kids asked me some questions about like weird bodily functions.
Right. Yes.
So I'm looking forward to this one.
I still want a full list because you've just said like farts and burps, and I don't think
sneezes.
are we going to talk about like vomiting and like
potentially
stuff?
maybe? Yeah, I don't know. I haven't put it all together. Kind of some of those unknown things, like that little hangy down thing in the back of your throat. Your uvula.
Oh, okay.
Kind of what that does, you know.
Okay, so kind of a grab bag of just weird parts of our body.
Yeah, I don't know what this thing does. Let's see. So,
all right, I will learn a lot during that episode.
I think a lot of us will.
For sure.
So, and then I'm also working on one more serious, obviously, seasonal affective disorder and what that's about, and then men's health as well.
Yeah.
So
yeah, I think that should all be good stuff. Men's health, something I don't think we talk enough about.
No, I really don't.
So yeah, I'm looking forward to that one too. I think I agree. That's a good serious episode.
Yeah, and it's not. So we've talked a lot about Mike's prostate.
Probably too much.
Let's be honest. We probably have, but it's going to be outside that. So it's
Okay.
going to be other things that impact men's health.
Okay, so non-prostate related men's health.
Yeah, we might throw prostate in there. We'll see.
Okay. I usually don't recommend throwing prostates, but I'll let you for this one time.
That could be an interesting visual. Now, I will say today's topic, again, potentially inappropriate medications in geriatric patients. This was a listener requested episode.
Oh, really?
So I want to throw a shout out to Riley Farwell, who submitted this topic idea. And I will say that this is near and dear to my heart because this is what I do here at the College of Pharmacy is that I teach a course in geriatrics.
Okay.
So this is a little bit of my specialty.
All right. So you're kind of the expert in the room.
I know that's seldom does that happen.
But when it does,
unless it's about big muscles or dunking basketballs, then yeah.
You do a really good job with that.
Yeah,
and
lifting
you're very
heavy
humble
things.
about it too, which is great.
Actually, humility.
Yeah.
Also one of the many things that I'm good at.
That makes a lot of sense. But thank you, Riley, for writing in to give Mark the opportunity to talk about one of his favorite subjects.
Yes.
Because I'm actually looking forward to this too, because a lot of patients that I work with do kind of fall into that geriatric category. Do we want to start by just like defining what you mean by that? Like, what does that mean?
So I'm basing everything today on what's called the Beers criteria, and we'll get into that in a little bit.
Made by Joseph Beer, who also invented beer, surprisingly.
That is not true. Not true at all. But I like where your head's at.
Okay, all right. I'm bringing the energy at least.
You are bringing the energy. I like that. No, we'll talk about the beers list and why it's called that. It doesn't have anything to do with IPAs, just a teaser.
Okay.
But in geriatric medicine, the definition of geriatric is actually starting to kind of shift a little bit. Years ago, 65. If you're 65 or older, you're geriatric. It was one day later when you turned 65, you were geriatric. And actually, that is what the Beers criteria uses. So 65 plus is considered geriatric.
Okay.
Outside the Beers criteria, some other criteria offer more of a sliding scale, if you will. So you really need to look at the patient. So it's not necessarily right at age 65. But if you have 3 chronic disease states and you're 63, maybe you're geriatric. If you are 75 but you're running marathons, probably not geriatric.
Right.
But there's still some things you need to think about, like your kidney function really is very much tied to your age. So no matter how healthy you are, you're going to have less kidney function as you age.
Yeah, and that makes sense. And I really like that it's now more of a sliding scale, like you said, where we're not just looking at age, we're looking at some of these other factors as well. Because you kind of alluded to this. There's no like magic number, right? Where it's just like, okay, it's 64, you're great, you're doing fine. You hit 65, boom, your kidneys stop working, your liver stops working, you can't move anymore. Yeah, that's not how that works.
It's definitely a sliding scale. And when we get in this space, we talk a lot about pharmacokinetics versus pharmacodynamics, two really big, important sounding words.
Right.
But pharmacokinetics is basically how our body treats medications, kind of how we get rid of medications. And then pharmacodynamics is the effect of those medications on our body.
Okay.
And as we age, both of those change. So we essentially can't get rid of medications like we used to when we were young. And then those medications have a greater effect on us as we age. And not just because there's more of them.
Interesting.
Yeah, so it is very interesting.
Okay, so I guess maybe as like a general rule of thumb, and feel free to correct me if I'm wrong, Mark.
Oh, I will.
Don't need to tell you twice, right? So yeah, in general, for our more like geriatric-esque patients, we're probably going to use lower doses of medications. Is that a good rule of thumb?
Yes, that is a good rule of thumb.
Okay. But it probably depends on the medication and I'm sure other factors too.
Yeah, we say start low and go slow. There are some exceptions that I start kind of nerding out with pharmacokinetics because sometimes if we slow, if we increase what we call the dwell time in the liver, so if medications move through the liver slower, like they would in a geriatric, our liver actually metabolizes them better. So there are very isolated incidences when geriatrics actually metabolize things better because their liver has more time to work on it.
Interesting.
That's the exception.
So I've like heard whispers of that before, but I've never actually heard that in like clinical practice. Are you going to get into that later?
No, I won't.
Oh, dang it.
Because I don't want to leave the listener with this idea that geriatrics metabolize things better. It's really not.
Okay.
And honestly, like you said, clinically, I don't know how relevant it is. It's more benchtop theoretical than actually in clinical practice.
Yeah, which is always interesting to think about. But yeah, the stuff that we care more about, at least with this episode and in this podcast, is what's really important for you guys, at home.
What you can, actionable things you can take as yourself if you're over the age of 65, or those around you, right? Yeah. So we all know people who are over the age of 65.
For sure.
A little bit about the beers list history. It is
not
named,
Joseph's beer, or what I said before.
No, whoever you said before was wrong. But if you would have hit the name right, that would have been great, because it is actually named after a person, Mark Beers.
Mark Beers,
who has an interesting history, and we won't get into that. But if you ever do want to Google someone and read about them, Mark Beers is an interesting study. But he was a geriatrician. He actually wrote the Beers criteria, the first Beers list, in 1991.
That is a year before I was born.
Yeah, so it's been out a while. And he's no longer with us, but his name carries on.
Okay.
And I think the original list, I should have looked this up, but I think it was like 8 medications. And it was like 8 medications that basically geriatrics, older folks should not take.
Okay.
It's since expanded greatly since then.
So is that because we've just come out with so many new medications, or is it more that we just know more about medications now? I guess.
Well, I think a little bit of both. There's a lot more medications.
Mhm.
There's more geriatric patients.
Makes sense.
And our understanding of how medications impact geriatric patients has also increased. And he basically listed kind of the dirty dozen, right, or the worst 8. And he did not. He made it very clear that this was not an exhaustive list. These are just the worst ones. So it's expanded a little bit since then. I think it's up to almost 100-ish
Oh, wow.
medications.
Okay. So I'm going to guess that there's like varying levels of severity, if you will, where like some of these are like, you probably can use them, but just be careful. And other ones are like, no.
And that's why they're called potentially inappropriate. So there's no medication on the list that is completely inappropriate.
Oh.
So in certain patients, they may be okay. But these are ones that we need to look at. So what I'm going to do is I want to play a little game with you.
Ooh, I love games.
Yeah. So I'm just going to throw out a medication, and I've picked ones that I think listeners will have heard of. And then I just want to hear your thought. Do you think it's on the beers list or not? And then I'll obviously give you the answer and tell you why.
Okay. So essentially, are they on the beers list at all? Not necessarily that these are like very serious ones, just they're on the list.
Exactly.
Okay.
So
I foresee that I will be not very good at this.
that's okay. And I think,
I love that.
I think the average listener would not be very good at this either.
Yeah.
So, all right. So let's just roll with them. Are you ready?
I'm ready. Let's go.
Benadryl.
So I'm going to say yes, that one's going to be on the beers list. And I'm going to also take a guess at why.
Oh, great.
I'm
Go
good?
for
Okay.
it.
So I know that Benadryl, generic is diphenhydramine. It can cause like drowsiness. So we know that it's one of our first generation antihistamines. And so if we give that to an older patient, it might cause some drowsiness, maybe some dizziness. So maybe it's patients at risk for like falling and like hurting themselves or like hitting their head on something. So I guess that's my thought. Lock it in.
Ding, ding, ding. You got, I'm going to keep score over here.
Can I dab? Victory dab? You getting this on camera, Andrew?
What is that?
He's nodding yes. It's a dab.
Oh, all right. That's nice. So you got that one right.
Okay.
And you hit about half of the reason why. What you said was on point. So what you said was correct. They also have anticholinergic effects that can cause delirium. So it's not just the drowsiness, the sedation, the dizziness that might make you fall. It can actually precipitate acute mania and delirium. So people can become disoriented at time and place and really have mental status changes with Benadryl. And it's in a lot of things.
Yeah, there's a lot of combo products.
Tylenol, PM, tons of sleep aid products. So that's bad. All right.
Yeah, and I think that's a good, just real quick, sorry to hijack it,
No,
but that's a good just piece of advice for people to look at the medications that are in your combo products. Like anything you get over the counter, like look actually what the products are, because it might have Benadryl in it, and you may not want to give that.
Yeah, tons of those. So, and it's not just Benadryl; it's all first generation antihistamine.
Right.
So that if there's an old antihistamine, it's on the list.
Okay.
All right, next one, Claritin.
Okay, Claritin, also an antihistamine.
Yep.
Brand name. That's a brand name. So that's loratadine. If I'm not mistaken.
Yeah.
So that one doesn't really have the same sedation effects as the first gen antihistamines. This one I'm not as sure about. I'm going to say no. I'm going to say it's not on the beers list.
Ding, ding, ding.
Whew.
Not on the beers list.
I was not confident about that one, but I'll take the point.
So if you're taking Benadryl for allergies, my kind of favorite go-to is instead use loratadine.
Okay. Or Claritin.
Or Claritin. So, any of the non-sedatings would be okay. Cetirizine, a little bit more sedating than the others, but I'm still okay with it. So Claritin is okay to use.
All right.
If you're geriatric.
Love it.
All right. Next one. Omeprazole, Prilosec.
Ooh. Okay. So Prilosec, a PPI, proton pump inhibitor. It's more for your if you're having heartburn or GERD. I'm pretty sure this one is on the beers list. I can't give you a specific reason why. So that's my guess. I don't have a reason though.
I didn't ask for reason. So you got this one right too.
Whew, but I'm an overachiever. I want
You
to.
are.
I want to be able to get it all.
But the reason, so our GI tract has developed, evolved over time, in that our stomach has an acidic pH. So it's a very low pH, 1, 2, whatever it is.
Yeah, and that helps us digest food and stuff, right?
Exactly, and absorb certain minerals and vitamins. And then the rest of our GI tract, the small intestine, large intestine, are basic, so a pH greater than 7.
Oh, I thought you meant like they enjoyed Starbucks and like UGG boots in there.
That means you're basic.
Yeah. Man, I need Forrest or one of our students in here.
Yeah. I don't know. I thought you were going somewhere with like a cigarette reference because that's a brand, I think.
Yeah,
but
nope. But you're talking about the acidity.
The acidity,
Yes.
right, is basic. So then we have this 1-2 punch where if our stomach can't do it, then our intestines can, from an absorption standpoint.
Okay.
And what happens is when we take proton pump inhibitors, it raises the pH, so the stomach becomes less acidic. And one of the things that we can't absorb as well is calcium. So what we found is they work amazing. I mean, they take your GERD right away.
Right.
No worries there. But we don't absorb enough calcium, and then our bones become brittle. And so the incidence of osteoporosis much higher in those patients. So we try to avoid the long-term use of proton pump inhibitors. So that is on the Beers list. So that leads to my next one. Famotidine or Pepsid.
Okay. So that one is also for like heartburn and GERD. I'm starting to see a pattern here where you're maybe doing like one that is on the Beers list and one that isn't on the Beers list. But I also know you, Mark. I know that you are very tricky and that you would intentionally try to deceive me with such a pattern.
You're a good test taker.
I was not a good test taker.
Really? That surprises me.
I do a lot of overthinking. And
See, I don't do a lot of thinking, so I did great on tests.
That's why we're such a good team, Mark. See,
Right.
we're on both sides. Okay, I'm gonna guess based on what you told me for why omeprazole is not preferred. I'm gonna say that this one's also on the Beers list with a similar idea that it's going to make it harder for us to absorb some of that stuff like calcium. No,
So-
my perfect record.
A few years ago, get this. This is why I brought this up, especially. A few years ago, you would have been right.
Oh, no.
So it was listed on the Beers list for a little bit different reason, in that it can cause some of those anticholinergic side effects
that you mentioned earlier.
if it's not used appropriately for renal dosing. So geriatrics don't need as much famotidine or Pepsid as younger people do. So the other thing is that there were more people that were staying on proton pump inhibitors when both were on the Beers list.
Okay.
And it's better to be on Pepsid because it's not as good at wiping out that acidity in the stomach.
And it doesn't last as long,
It
right?
doesn't last as long.
Okay.
So what they found is that you're absorbing more calcium if you're taking Pepsid versus a proton pump inhibitor.
Okay.
So famotidine is okay to use now. There are some exceptions where if you had delirium, dementia, probably not the best product for you. But other than that, it's okay to use in geriatric patients.
Okay. So you would say if you do have heartburn, you have GERD, you would recommend something like Pepsid or famotidine based off the Beers list.
I usually recommend something like Tums.
Okay.
Because Tums has calcium in it, calcium carbonate. So the calcium's helping your bones. The carbonate's sucking up all that hydrogen ion acid that's causing the GERD. So you kind of get a 1-2 punch there.
I can see now why they have you teaching this, Mark. You know all the tips and tricks.
I try. And they taste good.
They do, actually. They're usually not too bad.
Now, off topic. Would you prefer mint or fruit-flavored Tums?
Oh, fruit flavored. 100%.
Interesting.
Andrew's also nodding his head, giving a thumbs up. I think that's a clear answer. Why do you ask, Mark? What do you
I
prefer?
hate the fruit-flavored ones. I only will do mint. It's very polarizing. Nobody says, "Oh, I'll take either one." You want one or the other. It's just
Yeah,
very
like I don't know. I would have the mint ones, but I feel like if I'm having heartburn, like the mint also is like a fairly it's like an aggressive feeling. You know, you get that mintiness in your mouth, and versus fruity is just like
fruity.
Yeah, so
You're fruity.
I'll take that as a compliment.
I like it.
Okay,
Yeah.
thank
You know, it's just very polarizing. No one is like, "Well, I'll take either one." It's like, no, get the mint. So, or get the
or
fruity.
don't.
Or get the fruity. All right. All right. So going down our list, this one I really feel good that you're going to get right. Aspirin for the primary prevention of cardiovascular disease.
The fact that you gave all these additional details, I think I know where you're coming at with this. So when you're saying aspirin for primary prevention of some of these things, you mean the patient hasn't had one of those problems yet. So they haven't had, let's say, like a heart attack or a stroke yet. And so we're giving this aspirin to hopefully prevent that initial event from happening.
Yeah, and usually low dose. I should have said low dose.
Okay.
but-
Yeah. I did assume that, but yes. So like 81 milligrams of aspirin.
yeah.
I'm going to say that is on the beers list because, yeah, it can be helpful, but it's also pretty high risk for like bleeding too. And so does the benefit outweigh the risk? Kind of stuff we talked about in the last episode. I'm going to say that no, the benefit does not outweigh the risk.
Right. So, and you are correct.
Woo!
So aspirin,
Back on the board.
This was a new addition, though, to the 2023 beers list, which just updated. I shouldn't say new addition, but they strengthened the recommendation that if you're taking aspirin for primary prevention of heart disease, that you can continue on, but you should consult the prescriber.
Okay.
So it's kind of like you should think about it. If you've been taking this for your adult life, you should probably have a conversation with your provider about whether or not you should continue. And then the strengthened recommendation was we should not start aspirin for primary prevention. So we're no longer recommending people who are not taking aspirin for primary prevention to start. We just aren't doing that.
And this is specifically, again, for geriatric patients, right? If you're younger, this may still be a good thing to do.
If you're over the age of 65 and you've never taken a daily aspirin, don't start if you haven't had any heart disease.
Okay. Excellent.
Let's take a pause here, though, for the Healthy Minute. So the Healthy Minute is brought to you by the winery at Young Farms. And today's Healthy Minute is protect yourself from mosquito-borne illness. So mosquitoes can carry and spread diseases such as West Nile virus, dengue fever, chikungunya disease, eastern equine encephalitis, malaria, and Zika. No matter where you live, you are at risk for contracting a mosquito-borne illness. But when you're traveling, it is very important to understand the risks of contracting mosquito-borne illnesses that are common to the area. To protect yourself, wear hats, long sleeves, socks, and pants whenever possible. Also use mosquito repellent with at least 20% DEET, as that will also repel ticks. That was the Healthy Minute, brought to you by the winery at Young Farms in Mecosta, Michigan. Please visit www.thewineryatyoungfarms.com for more information. Now, back to the Health Deli.
Love it. You're getting really good at those, Mark.
I try to really do that now. Back to the Health Deli.
And I can see just a twinkle in your eye when you do it, too. He loves it.
I do love it. You don't know who Paul Harvey, have you heard that?
I've heard the name, but I can't really say too much of who he is.
Andrew, are you familiar with Paul Harvey?
I'm thinking of Steve Harvey.
Well, Steve
Different
Harvey
person.
hosts Family Feud,
Right.
not related to Paul Harvey.
Okay.
No, he was a radio show. He had a radio show. America's Most Trusted Newsman. Had the perfect radio voice.
So that's where you're getting all that from, then.
Yeah, I
You're
used to listen to his
him.
show. And then he had a show called The Rest of the Story. It was like the original podcast.
Oh,
And he would just tell some famous person story. It was amazing.
that's pretty cool.
I'm sure you can find him on YouTube. All right, so let's get back to the list. I have a few more here. Where am I at? Here we go. So you probably heard of this. We were kind of switching away from over-the-counter meds for a little bit. But what about Paxil? So paroxetine, the antidepressant Paxil.
Okay.
Very commonly prescribed.
Okay. Yeah. And so I'm going to just give guesses from now on because I don't want to go over because I'm just seeing that we still have a couple of meds to go through.
Yep.
So I'm going to say yes. Paxil is on the beers list.
You are correct.
Whew.
So it is on the beers list for anticholinergic effects. So it can precipitate some of that delirium, a little bit like those first generation antihistamines. So Paxil, you are correct, is on the list. And the other thing is there's so many better alternatives. So when Paxil came out, it was one of the first SSRIs. Now we have a lot of SSRIs and other antidepressants. So there's better options. So in the same kind of vein here, Prozac.
Okay. Prozac, I'm going to say no, not on the beers list.
Whoa, you actually got that. I thought sure you were going to get that one wrong. Now,
It's that pattern I was talking about before.
Now, I don't want you to think that Prozac is safe in geriatrics because it's not at all. So it has this metabolite, norfluoxetine, super long half-life of that active metabolite.
So it just lasts in our body for a very long time.
Causes
essentially.
sedation, increased risk of falls, but it's not on the beers list, and this is very important because that side effects of Prozac are not unique to geriatric patients.
Huh.
So it's not a great med for geriatrics. It's really not a great med for younger people either because it has side effects. But it's not uniquely bad for geriatric patients.
That's very interesting. I
Yeah.
feel like if
So-
I were Mr. Beers himself, then I
Yes.
would still have that on the list because it
It would-
still is a concern.
And
I feel like
the reason that they started pulling some meds off like this
Mhm.
that were previously listed is because it was getting too big.
I guess that makes sense. You said there's about 100 on there.
Yeah, there's 100 right now. So,
That's fair.
but I don't want you to think that just because it's not on the beers list means it's a great med. So,
Okay.
I mean,
So what you're trying to say is I was right, but in spirit, I really wasn't right.
no, I'll give it to you. You were right.
Okay,
I'm not gonna put an asterisk on it. Mike would have. But
That's true.
I'm
He
not
does that.
going to. Here's another one. Cymbalta in the same class as antidepressants.
Okay. This one's slightly different than the ones you talked about before. I'm going to say yes, it's on the beers list.
So it is. Yes, you are correct. But this is another one that I thought maybe you'd get wrong because we use it in geriatric patients all the time.
Mhm.
It has some unique effects to treat urinary incontinence as well. It's a med that I routinely recommend for geriatric patients. However, it is listed on the beers list because it needs to be dosed appropriately based on renal function.
And that might not happen. It's kind of what you're saying.
Is the normal dose would probably be too much for geriatrics. So they need a little bit less based on their renal function. So it's listed
Mhm.
and it's a great med for a lot of geriatrics, but it's listed because we need to look at it just a little bit closer. Make sure it's got the right dose for that patient.
Okay. So that's more of just like a warning for providers like us to be like, hey,
Yeah.
just need to take a look at
Yeah,
it.
this is a good med, but you got to use it appropriately.
Okay. Love it.
All right, back to over the counters. I probably should have grouped this a little different, but that's okay. Motrin.
I feel very confident. Yes, that is on the beers list.
Yeah, so all NSAIDs are listed because of GI side effects, and that's probably not any surprise to a healthcare professional, right? Oddly enough, if a patient needs to take an NSAID, they actually recommend coupling and starting a proton pump inhibitor.
On the beers list, it says that?
Yes.
Very interesting.
It's a point of contention because proton pump inhibitors are on the beers list. So if you're using a beers list med, you want to add another beers list med. And I tend to avoid NSAIDs because of that. So if you do have to start an NSAID, this idea that now you're starting a proton pump inhibitor, which all of the problems with that, it's probably not a good idea.
And kind of the reasoning there is that the ibuprofen or the Motrin can cause bleeding in your stomach, right? Which the PPI would hopefully help, but then you have all the problems of the PPI and
exactly. Yeah. So let's just not have an ulcer.
Right.
So I try to use things other than NSAIDs, but we'll talk into some of those options might be on the beers list as well.
Oh no.
Yes. Tylenol.
Okay. I feel less confident about this one. I feel like you're due to trick me. So I'm going to say not, or no, I'm going to say yes, it is. Yes on the beers list.
She overthought it. Tylenol, not on the beers list.
That's what gets me.
And we could have a whole episode about how much Tylenol is too much, because if you ask one geriatric practitioner how much Tylenol you should take, you're going to get a different answer for every single person that you talk to. But it's in my mind, if you're taking less than 4 grams a day of Tylenol, which is the same maximum dose of any other person, any other adult, that's okay. So Tylenol is an option for geriatrics pain control.
Okay. Yeah, I thought that one might be another one of the warning things, because I've definitely had patients that have accidentally overdosed because they took too much.
Yes.
And so that was the angle I was shooting for.
And hepatotoxicity is what we fear with a high dose of Tylenol.
So like liver damage, you mean?
Liver damage, right?
Yep.
So for a long time in the geriatric world, we said like 2 grams was enough, was the max dose. And then we kind of moved to 3, and now we're kind of like, well, actually
we're back with everyone else.
Yeah. So, and next year it'll probably change. That's just how it is.
For sure.
So what about estrogen? Estrogen therapy.
I I'm pretty sure. I would say yes. I'm gonna say yes. That's on the beers list.
It is on the beers list. So very commonly prescribed, but it was added to the beers list quite a number of years ago due to increased cardiovascular risk.
Hmm.
And this is only oral estrogen products, so systemic estrogen products that you generally take for postmenopausal symptoms.
Right.
The exception would be topical estrogen. So topical estrogen for vaginal discomfort is still okay.
So you're talking about like creams and that kind of stuff.
Yep, suppositories, things like that are still okay. But oral estrogen forms are not. So it's okay to use them right around postmenopausal symptoms for symptom control, but long-term use is dissuaded. We used to think that, and there actually is a little bit of osteoporosis benefit for with that estrogen supplementation,
Right.
but the risk of the cardiovascular risk is higher. It negates that benefit of the osteoporosis.
Right.
risk.
Plus, we might have some other things we can use for osteoporosis too, right? That don't have those risks.
Exactly. A lot of other things. So,
Okay. Makes sense.
So it's good for symptom control, right, when the patient needs it, but not long term.
Mm-hmm.
What about testosterone?
Yes,
Near
testosterone.
and dear to my heart.
Because he has got so much.
Yeah. Endogenous, though, not,
Right. And so I'm going to say that this is on the beers list. I'm going to say yes. I don't feel incredibly confident about it, though.
Yeah. So in kind of that same idea, increased cardiovascular risk, it is on the beers list.
Okay.
I forgot to write down your last question. And it's bad for prostate problems. So as we get older, us men, the prostate is a doomed organ, as we've learned from Mike.
Yeah.
So
unfortunately, he's not here
to defend himself. I love it. So the problem is it causes more prostate problems in an already population that has prostate problems. So
Makes sense.
Yeah, we don't want to do that. Okay, a couple more. We're moving to antibiotics, which is right in your wheelhouse.
I'm ready. I'm ready for it.
So Bactrim, sulfamethoxazole trimethoprim.
Okay. I'm going to say yes, because a lot of the times these patients don't have great kidneys. And so that can cause our side effects to get a lot worse.
Yes. So it's on there actually for two reasons. The one that you talked about, you have to use it appropriately based on renal function. The other one, though, is it actually increases potassium with ACE inhibitors and ARBs.
Which most are probably taking.
So the beers list also has another table now that talks about potential drug interactions, common drug interactions.
Okay.
And this is one of those common drug interactions that we see.
Okay.
What about Keflex, cephalexin?
Yep. I'm going to say no on that one.
Yeah, very safe med.
So love me some Keflex.
Oh, yes. So Keflex is okay to use in geriatrics. Now,
not a lot of side effects, well tolerated, works really well.
And it works well.
It's lovely.
Yeah. And I don't want you to think that every other antibiotic other than Bactrim is okay. There are other anti-infectives listed on the beers list. So
for sure.
Now we're going to go antipsychotics.
Just in general?
We're going to say first generation, typical antipsychotics, and atypical.
So these are both together? You want
all antipsychotics? Okay. So we're talking like Zyprexa, Haldol, Abilify, Seroquel.
I'm going to say that they are on the beers list. I know a lot of geriatric patients that are on these, but I'm guessing that it's on the list.
They are used in a lot of geriatrics, but you're exactly right. It is on the beers list. There's actually a black box warning on every atypical antipsychotics, which is a warning right on the package insert that comes with the medication, that there's a increased mortality risk 1.7 times. So you're 1.7 times more likely to die while taking these for all-cause mortality.
Okay, that was going to be my next question. Like, what is causing it? But it's
all-cause mortality. And we could have a whole nother episode just about that as well. And I have some theories, and everyone has theories, but basically, these medications increase the risk of dying.
Interesting.
So, yeah.
I'm very interested in that. Like, what causes that to happen?
Yeah, and a lot of it has to do with cardiovascular, honestly, because these meds have increased risk of diabetes, dyslipidemia. But what we found is even with the newer agents that are cleaner from a side effect profile, they still have an increased mortality risk. So then we thought maybe it was like fall risk because they, cause some obviously CNS changes, mental changes, make ataxia, movement disorders.
Right.
So even when you have the newer, cleaner agents that have less fall risk, still more likely.
Wow. That's
So,
very interesting.
Yeah.
Huh.
And then you could take it all the way back and say that, well, the patients that are taking these meds have, complicated disease states, and maybe that.
Right. Because that's why we're starting them.
Yeah.
Kind of thing. So maybe we're just selecting for patients that we're going to.
So we don't really know why, but we know that these meds, for whatever reason, are, if you're taking these meds, I need to say that appropriately. If you're taking these meds, you're more likely to.
Right. And you're a geriatric patient, right? Like if you're not geriatric, you should definitely still be on your antipsychotics.
Yes. Yes. Don't stop taking them. And like I said, we still use these routinely, but we have extra monitoring and we watch these patients more closely than we would. So I'm not saying that it's bad for every single geriatric patient. We just need to look at them a little more closely.
For sure.
Right, so I have a couple more. Benzodiazepines.
I feel confident on the beers list.
Yes.
Anticholinergic, dizziness, fall risk,
everything.
all that stuff.
So your Ativans, your Valiums, Xanax. I think both antipsychotics and benzos were on the first beers list, and they continue to be on the beers list.
That makes a lot of sense.
Increased risk of falls, just everything like you said. Muscle relaxers, Flexeril, Baclofen.
I'm going to say yes. I don't feel as confident about it, but I'm going to say yeah, they're on
You
there.
are correct, but interestingly enough, a recent addition.
Really?
Yeah.
So I figured like they'd have those ataxia, so difficulty moving, some of the dizziness.
I think this definitely was on the radar of most geriatricians, not to use muscle relaxers, but they were added. And there's a strengthened recommendation that kind of unites all CNS drugs, so central nervous system acting drugs, so things that cross the blood-brain barrier and cause like changes in your mental status a little bit.
Yeah.
Anything that crosses that blood-brain barrier and is considered psychoactive, the Beers list has said that any 3 of those, if you're taking any medication, any 3 medications that are psychoactive, that's potentially inappropriate. It doesn't matter what class they are, any 3. So if you're taking, and these are the classes that they actually list: antidepressants, anti-epileptics, antipsychotics, benzodiazepines, Z drugs, which are your sleep inducers, Ambien, Sonata, those kinds of meds.
Okay, Zolpidem, all that stuff.
Zolpidem.
Okay.
Opiates, any opiate.
Any opiate, okay.
And including a muscle relaxer. So if you look at all of those different categories, and if they're taking 3 or more, that's potentially inappropriate, just because of the increased risk of falls.
Yeah, because those side effects all kind of like build on top of each other, right?
Exactly. And if geriatric patients fall, they don't have the bone health maybe to support that, you end up with a fracture.
Right. Your muscles aren't as strong as they were before, so you might not be able to get up. Yeah, there's a lot of problems there.
Yeah. Well, I think we hit the major ones that I wanted to talk about.
Yeah. Thank you, Mr. Joseph Beers, for putting together this list.
Mark Beers.
Mark Beers, of course.
Yeah. So I want to thank Riley for suggesting this episode. So I think that this is a great episode. If you, one of our listeners, have an idea for an upcoming episode, please email us. And our email address is healthdeli@ferris.edu. So thanks, Ben. And hopefully we can get back together in this beautiful studio and record another episode.
I'm looking forward to it. I'll see you next time.
Thanks for stopping by the Health Deli to sample some of our wares. We're open 24/7 on Facebook and Twitter at The Health Deli, or visit thehealthdeli.com to send us a question or find any of our locations. Please come again. We will be regularly stocking the shelves with fresh content and new wellness specials. As always, we want to give a special thank you to Andrew Tingley and the crew at Ferris State University's Television and Digital Media Production Program. Until next time, so long from the Health Deli, where the topics are tasty, the takes are fresh, and the discussion is free.
That is my favorite sound clip. Am I Klebster from the Health Deli? You heard of us? No. You really should just have that at the end of this episode, because Mike's not here.
That should be at the end of every episode.
So I'm Mike Klepser. I'm from the Health Deli. That's a podcast that we have here on campus. I'm sure you listen to it all the time.
Nah, I don't.
Hi, I'm Mike Klepser. I'm from the podcast, The Health Deli. I'm sure you listen to it all the time, right?
No, sorry.
Hi guys, how are you? Good. I'm Mike Klepser. I'm from the Health Deli. I'm sure you guys have heard of us, right?
Maybe,
on campus?
Maybe, yeah.
No, you haven't.
I love it. It's a great
I'm
club.
Mike Klebster from the Health Deli. You probably heard of us. No.
So good. So good.